Good morning, everyone. My name is Beth Lamar. I'm the Executive Director of NAMI Rhode Island, for those who don't know me. And this morning we are joined by Dr. Kevin Bale, who serves as the Associate Chief Medical Officer and Chief of Addiction Services at Butler Hospital. Dr. Bale is going to deliver a keynote address to us today on the state of mental health. And without further ado, I'm going to turn the microphone over to Dr. Bale. Thank you.
Thanks so much, Beth. And thanks to NAMI of Rhode Island for this opportunity to speak to all of you today. It's really an honor to get to talk to the community like this, even if we're still doing it in a way that is virtual rather than in person. I do have some notes here, but I haven't given a keynote address before, so bear with me. And if you do have any questions or want to engage through the chat to kind of help me along, feel free. What I was planning on doing today is to talk to you a little bit about my background and where I come from, so that in this sort of vast expanse of the topic of mental health, you understand where my remarks and my perspective come from. I would like to talk to you about a good working definition of mental health, and in that way to understand some of our current challenges, including, of course, our current experiences through the COVID-19 pandemic, as well as some current efforts and opportunities that we're working on to try to address the situation that's in front of us. So I hope that I can get through all of that and keep you somewhat engaged along the way. So my name is Kevin Bale. I'm a psychiatrist, which means that I'm a medical doctor by training. I did my residency in New York City, and it was a very vibrant place to become a psychiatrist. A lot of other professionals and a real diverse patient population. I did a fellowship in public psychiatry at Columbia, which meant that I got a chance to work in a homeless outreach program. It was my first job out of residency. And our program gave peanut butter and jelly sandwiches to street homeless people in Central Park and the Upper West Side, and engaged them in services gradually on the way to permanent housing. And that kind of work has really been influential to me over the years. I've tended to be in public and community settings, including all the way up to Butler, which you might not think of as a community setting, but really is a safety net hospital for the city of Providence and Rhode Island in general. And just in terms of thinking about where my perspective comes from, one of the little quips that I like to start off my lectures to medical students are, I'm not a researcher. I'm really not an academic. I learned most of what I know about mental health and substance abuse on the streets of New York, in Maine, and now in Rhode Island. So for the last 12 years, I've been working at Butler full-time, and I was a chief of one of our intensive treatment units, which means that I worked with a lot of people with chronic mental health problems and developmental disabilities. That we worked a lot with patients who were involved with the mental health court to be court ordered for treatment. So kind of gained an understanding of that arm of our work, and then moved on to a focus in addiction services. I'm currently the president of the Butler medical staff, and also, as Beth mentioned, the associate chief medical officer. I also have I'm a director on the Care New England board, and have been involved in discussions about how our health system, Butler Hospital is part of a health system called Care New England, and how our health system can become more financially secure. For a while, we were recently trying to do that by merging with Lifespan Health System, which is Rhode Island Hospital and Miriam Hospital and some other facilities. And now we're exploring other options. So there is a way in which you kind of gain more jobs as you go along in this business. And hopefully you don't mind me juggling and toggling back and forth a little bit. I am also currently involved in a master's program at Brown University called a Master's in Healthcare Leadership. And the reason why I mention this is because in a minute, I'm going to read a couple of paragraphs from a paper I wrote recently because I think it sort of frames up my perspective on mental health and on some of the impacts that we've been experiencing since early 2020. So what I want to do now is pivot towards talking about a working definition of mental health. I think this is important because it's a little bit difficult for people to grasp in a way that differentiates us from physical health. You know, patients typically go to an emergency room with a physical problem that, you know, they're easily able to identify. So, you know, if you have a chest pain or you have a broken leg, you can go to a doctor and the doctor says, what's ailing you? What brings you to the hospital today? And you can easily explain to them what the problem is. And in mental health, we don't have that. We don't have that sort of ease of understanding. So one of the I think foundational things for us to think about is about the human brain and how the human brain is constructed. And I'm not going to get too technical, but I'm going to propose to this group that our human brain is really composed of three brains, one stacked on top of another. We start off with a reptilian brain. The earliest, you know, central nervous systems on this planet belonged to reptiles, and the brains of reptiles are involved in instinctual behaviors and with regulating our bodies. So our brains work to keep our heart beating at a certain rate, and our brains work to provide certain reflexes. When there is a dangerous situation, our brains turn on certain switches and make us ready to engage in either fight or flight type of responses. Our brains regulate our temperature. Our brains tell us when we're hungry or when we're sleepy. And these are all functions of the reptilian brains, the oldest brain, thinking from an evolutionary perspective. So on about a few, you know, hundreds of million years go by and we arrive at a mammalian brain. And the mammalian brain sits on top of the reptilian brain and provides another layer of sophistication in that mammals do things that reptiles don't. They engage in more sophisticated and abstract behaviors than reptiles. They have relationships, mammals do with one another. If you think of a pod of chimpanzees, are often engaging with one another, and they have a social hierarchy, and they you know, express something that seems to have an affinity with human emotions, right? either negative or positive. They communicate in rudimentary ways. They can use tools in rudimentary ways. So those are all aspects of the mammalian brain that sort of reflect an advancement, a sort of new level of technology on the earth. So on top of the mammalian brain is the final layer, the human brain, the cerebral cortex, which is really kind of like the newest and latest refinement in central nervous systems. And what the human brain, that final kind of small little layer of neurons that are behind our foreheads and behind our eyes, enable us to be able to do things that mammals can't do. So our use of speech, right? Our ability to plan ahead, to envision a future and engage in activities that would help to position us for that future. Our abilities to delay gratification, all things that the mammalian brain doesn't really have the hardware to engage in. I think about my hound dog and the kind of attention span that my dog has, and my dog's inability to reflect on certain behaviors. The dog definitely feels joy and definitely can feel shame, but can't necessarily put together past experience and learn from it. Or for that matter, I think about things that my dog can't seem to do. My dog is very interested in food. If any of you have dogs, you know that this is pretty typical, that they're food driven. And that makes sense. But I'm always struck by the fact that if I give my dog some food, it's not like my dog's able to really savor it or enjoy it. He just kind of gobbles it down. And it doesn't matter whether it's, a milk bone or filet mignon. He doesn't have that capacity because that's part of the human brain. So I just want to bring that kind of concept to you, that we have a reptilian brain on top of and then on top of that, a mammalian brain, on top of that, a human brain. Because I think increasingly in our world, it's the human part of the brain that we desperately need in order to be happy and healthy and whole. And it's also the part of the brain that needs connection with other people, and also, needs to be grown. It takes a long time to grow the human part of our brain. We're born with the reptilian part. It's almost fully functional within the first few weeks to months of life. Whereas the human parts of the brain, we have to go through, an entire childhood and adolescence and young adulthood before we really can take full advantage of our cerebral cortex. So as far as a working definition of mental health, I want to put to you the idea that the key ingredient to good mental health is the health of our social networks, because mental health relies on that mammalian and human parts of our brain. And in order for us to be not depressed and not anxious, we need people in our community to be giving us kind of good vibes all the time. And that's been a struggle that we've all gone through lately. And the pandemic is part of it. And I think, social media and our kind of communal addiction to our phones is also taking away from our ability to relate to one another in real time, in ways that make us feel confident and safe and reassured. So I'm just gonna read a a couple of paragraphs. I promise I think this will be helpful, but this sort of is some reflections that I had on the pandemic and how what we experienced during it. While mental health impacts of the pandemic have been part of the national discourse, a coherent public health strategy addressing these concerns has been lacking. This is not due primarily to a lack of attention or resources. It is a failure of imagination. Policymakers have struggled to articulate the mechanisms by which mental health of a population improves or deteriorates, blunting the effectiveness of interventions. While physical illness, I mentioned this already, while physical illness is readily understood by providers and the public alike, mental health problems tend to confound and confuse. Banal inquiries in a clinical interview, such as "What brings you to the hospital today?" are often complex and profound in a psychiatric framework, as distinguishing from a broken arm, chest pain, or bleeding. At a population level, increasing prevalence of mental health problems can be related to a degradation in social networks. There is a literature which recognizes the impact of loneliness and social isolation on mental and cardiovascular health. Quite literally, in the last 2 years, we have broken a lot of hearts. The anthropologist Robin Dunbar has explored the link between brain size and social networks in primates and famously proposed that human beings have an upper limit of 150 friendly relationships. You can only have 150 friends, according to this anthropologist, because of the size of our brains. These relationships are of a casual and affiliative nature. Quote, people you wouldn't be embarrassed to have an uninvited drink with. In contrast to the intimacy of household members, immediate family, and lifelong friends. Indeed, although not without criticism, this group size correlates with our understanding of hunter-gatherer societies. They're about that size. Maintaining a network of trusting, non-threatening relationships is typically achieved by primates through close contact, including grooming. Think about the chimpanzees. Pandemic restrictions on social gathering and masking have had a deleterious effect on our ability to maintain casual social connections that communicate warmth and benevolence. Even the security and relatedness conveyed by a handshake was recast as both a social transgression and a potential hazard. Without the ongoing nurturing of informal, in-person social networks, and amidst a parade of frightening headlines, the citizen's sense of emotional safety withered. It is not surprising that the constriction of American civil society has been accompanied by an epidemic of mental illness. Armed with this ideologic construct, one begins to see the outlines of a sensible public health response. So what did we see? We saw over the last 2 years a 30% increase in overdose deaths. 30%. We saw over the past 2 years a quadrupling of patients reporting depression, anxiety, and suicidal thinking. So a sort of tidal wave of problems that come about due to this degradation of social networks. So what are our challenges? Our challenges are this, an unprecedented amount of need for behavioral health services, a lack of coordinated systems of care in Rhode Island. All of the hospital systems are financially challenged. There's not a healthy, from a financial perspective, a healthy hospital in our state because of the payer mix and because of state regulations. We're all kind of on life support. And so our ability to coordinate care and our ability to innovate is hampered. We have a hard time with recruitment and retention of professionals, psychiatrists, as well as clinicians, nurses, mental health workers, occupational therapists, activities coordinators. At every level, we have a tough time because our healthcare system is under stress. And just even in terms of getting a job, if I can cross state lines and go to a state which might have a healthier healthcare system, they might be able to pay me more. They might be able to give me more robust benefits. And so that's been a big challenge. We have an enormous challenge with access, especially in the behavioral health realm. Every day, our emergency room at Butler has patients who weren't able to find a bed overnight. Every day, there's patients in hospitals around the state who are seeking mental health care who don't have a bed readily available, and they can't safely go home. They might not have a home, but they also don't have any place to stay, and so they end up staying in emergency rooms. These problems with access are particularly acute in some special populations. So adolescents and young adults who I think have been particularly impacted by some of the recent factors that I mentioned are facing a crisis of lack of access to timely behavioral health care. There was an article in the New York Times just last week, I believe, and this is not just a Rhode Island problem, it's a national problem. The kids are spending a week or more boarding in an emergency room, essentially receiving no care or only the most rudimentary, pharmacologic care, certainly not the kind of support that one would need when they're in emotional crisis, while waiting for a safe place to go. The geriatric population is also facing a most acute resource access problem, as well as our developmentally delayed population. To some extent, these special populations, young adults, adolescents, geriatrics, and the DD population, to some extent, even before COVID, these problems existed. They've been exacerbated. Also, at the hospital level, I should just mention that we've seen a dramatic increase in the cost of care. The cost of care to provide what people need has been rising, especially due to staffing problems. And that's made our financial health even more challenged. So what are we doing? What are we doing about all of this? So I'm just going to tell you a little bit about what at Butler we're doing. We've made a real big push to incorporate advanced practice professionals, including NPs, NPAs, and we're giving them behavioral health expertise so that we can have more providers at hand. I'm just seeing in the chat, I agree that many or all of the problems that I've talked about did exist before COVID. I would put to you that the trends, socially, even beyond behavioral health, have been exacerbated by COVID. It's not that COVID brought, all that much that was new under the sun. The sort of racial inequities and challenges to our educational system and challenges to our health system, they all existed before the pandemic, but they've just kind of thrown into much more relief. So we're working with increasing our bandwidth by really developing NPs and PAs and encouraging psychiatrists to work with APPs to broaden their scope. There has been an increase in coordination statewide to make inpatient behavioral health treatment accessible. We had a real, what we saw as a big success in January during the Omicron surge. Butler Hospital was, with the help of the Rhode Island National Guard, we were able to open up a auditorium, Ray Hall, and treat patients in what we called a brief stay unit in the auditorium. And it wasn't like a normal inpatient unit, but we were able to relieve some of the pressure on the medical hospitals. And instead of closing down behavioral health beds in the midst of the crisis, we actually expanded beds, and we're very proud of that. And we see that as possibly a model for going forward to hopefully expand and offer a brief stay unit, because the situation in the emergency rooms around the state is not helping. It's not helping patients. It's not helping providers, and it's not helping our healthcare system in any way. We're looking to open an assessment center at Butler to provide more support for primary care practices and patients that are waiting to get a diagnosis, to get started on treatment. We are really interested in the idea of moving behavioral health care from a fee-for-service model to a value-based model, a sort of population health approach. So rather than getting paid for each visit, for each patient that we see, we would like to take a look at providing some kinds of care that aren't ordinarily reimbursed, in the hopes of decreasing future admissions to the hospital, to support primary care practices and in holding on to patients that are struggling, because the wait times to get into see psychiatrists are really not feasible for most people, and we don't want to have to wait until a crisis occurs to intervene. If there's certain kinds of interventions or treatments or medications that could get somebody back to good health, we don't want to have to wait 6 months and make things get worse. I do see that we have only a little bit of time left. And I think I've said a little bit. I do see a mention in the chat about peer support. And I think peer support is also an important component of that move to quality that is really important. One of the barriers to peer support, over the years has been that it's hard for us to offer services, at least in the hospital framework, that we can't code for and we can't bill for. And a lot of payers have been hesitant about funding peer support services. So if we move more towards a quality model and can demonstrate cost savings by incorporating peer support, that would be an improvement. So as far as whether you can bill now, it depends for peer support. It depends on the payer. And a lot of the managed Medicaid payers are still not making it easy to bill for peer support. I do think that this is an area that we're going to continue to see improvement in going forward. But whenever you kind of have a fragmented reimbursement, that limits our ability to, if we have 30 patients that need to be seen and 5 of them have one insurance and 5 of them have another insurance, and 10 of them have something else, and every plan pays for some different amount of care, it makes things kind of hard to figure out how to implement and utilize our staff. So in some settings, peer services are billable, and sometimes they are not. Yeah, I think if I could encourage anything on that front, it would be, can we have uniformity in terms of support for a service like peer support? That would make it a lot easier to implement across the board, so we don't have to discriminate between patients that have Medicare versus those that have neighborhood versus those that have commercial insurance, and so on. So I really appreciate your time, and this 30 minutes went a lot faster for me. I hope it didn't drag on too long for you. And I want to thank this community for being engaged in this work, for shining a light and for combating stigma. We need to continue to do everything that we're doing and continue to innovate. There's definitely a lot more work to be done. and thanks all for listening.
Thank you. We really appreciate you opening our day today and giving us all these thoughts that I think will carry on throughout the theme of our other sessions. So I appreciate you speaking for us this morning, Dr. Bale, and I hope that we're able to do more things like this moving forward as well. So you have a great day, and for everyone else, I'll see you in the remaining sessions.
Thanks. It's been a pleasure.